Hello, everybody. Recording live from somewhere. This is Zach Couples with episode number 31 of the Movement Debrief. And this is looking to be the best one this year, folks. See what I did there? We're going to talk about all types of cool things. We got SI joint pain on the docket. We got slideboards on the docket. And we got bulging discs on the docket. Ooh, edgy. So that's what we're going to talk about today. But first, a little bit of housekeeping. Did you guys see my blog this past week? This one was the links from the month of December. There's a lot of good stuff on the interwebs in December. So probably my favorite, and I know this has been shared a couple times, but Peter Attia had just a phenomenal one. He's an MD, does kind of like, I don't know if I would say like functional med kind of stuff, but I don't know. He's kind of like a MD who thinks a little bit outside of the box. You guys should check that one out. He's going to be starting a new blog at some point. I can't wait for him to do that because he's very, very, very smart in that regard. And James, thank you for being here. So that was this week's blog. What else is going on? Human Matrix. September 15th to 16th. Guys, that is like around the corner, fam. Are you excited? I'm excited. You guys should sign up. It's going to be in Seattle. Well, actually, I don't think you can sign up yet, but I do have the outline done. I started working on the PowerPoint and all that jazz a little bit, so I'm pretty jazzed about it. Hang on, let me just put some minerals in my water. So yeah, we got that coming up, and I figure I'll announce this now, but I'm hoping that sometime in the first part of this year, I'm going to release a product. So I think it'll be good. It's going to be kind of like a series of case studies. It's going to be like live case studies, watching me kind of do my thing, and I'm going to kind of talk through some of this stuff, and it should be pretty cool. At least I hope it will be. So that's kind of the game plan for this year, 2018. So you heard it first, you peeps live. Be on the lookout. I'll keep you posted. Otherwise, Happy New Year to everybody. I hope you guys all had a wonderful time. I had a pretty good time. So it was good. So look forward to 2018. 2017 was fun. It was fun getting back into the swing of things with this. And I hope the new year treats all y'all well. And I hope 2018 brings you lots of good stuff and you keep getting after it. So without further ado, let's debrief, shall we? First question comes from my boy, Chris, who I used to work with a little bit in Illinois. So he wants me to talk about the relationship between pelvic position and right versus left SI joint pain. FYI, mine is always on the left. I can't watch live, but I definitely catch all the episodes. Keep up great work. Thanks for all the time taking to do this each week. Chris, thank you for a wonderful question and your contribution. So that's what we're going to talk about first, SI joint pain. So here's the deal. Two things. Well, one thing. It's really no different than any other condition, the way I look at it from a clinical standpoint. So what we're going to talk about is what do we have to look at to, from a clinical standpoint in the sense of any other condition, right? The treatment process is the same. You're going to restore variability. You're going to build power, build capacity, get after it, get them out of the clinic. And with SI joint pain in particular, I don't necessarily look at any of like the special SI joint tests. So the Hackett cluster, I think it was. I forget. But there's like, compression and all these jazz. That doesn't help me at all because with something like SI joint pain, if it's localized to the joint and barring that there's no mechanism injury that would make you think there's some type of fracture through the pelvis or something like that, those types of tests don't really add much. But I do think that pelvic positioning type tests, and I'm not talking motion palpation or any of that BS that they use to check SI joint pain, which has been shown to be incredibly unreliable, as has all the tests regarding the SI joint. That stuff's not helpful to me. What's helpful to me is assessing how well an individual can move in 3 planes. And if I have someone who has limitations in multidirectional hip motion, especially extension, adduction, these types of things, we can reason to believe likely that there is some type of extension going on within that region, because extension reduces degrees of freedom. That's why it is the closed pack position for many joints, because it provides passive support and stability. So you check that. Now, a lot of times what you will see is one of 2 cases. Dexy, how you doing? You'll either see someone who has very little motion on one hip, and that could signify that the innominate is probably tipped a little bit more forward. So you might see limitations in adduction, extension, all these types of things. Maybe a little bit of compression through the SI joint. Relatively. I mean, fam, let's not get it twisted. This joint don't move that much, but it does move. Let's also not get it twisted. So you may see that. What do? Restore the motion so you can alleviate some of the compression. Another thing you could see is maybe they have SI joint pain on one side and there's a lot of motion present. Maybe they have full hip mobility, but they're still having pain. Well, maybe what that is a combination of inability, or it's an inability to offload the affected side. So the fix could still be addressing the side that's contralateral that has mobility limitations or movement position limitations. So that side can be offloaded, and that can be a combination of doing things on the non-involved side, which, trick question, there is no such thing as a non-involved side. So doing things on both sides to address the movement limitations. And so always think, is the reason why I'm hurting in a particular area secondary to a lack of motion in surrounding areas, or is it because I have motion there and I just can't offload it because of the opposite side? And if you address both of those things simultaneously, you ought to be in business. So, good question, Chris. I don't really think I don't want to say that there is a difference between left and right SI joint pain, because I think it's so dependent on how one presents from a motion or lack of motion standpoint. Because you could play biomechanical games that I could be getting this pain on, you could have 2 different people who have right SI joint pain for 2 different reasons, and they could have 2 different biomechanically tested things that are contributing to that. And so the fix is the same. Restore variability. Once you've done that, do some things that would involve some loading. Now, one thing you may want to be careful of with this is single leg based exercises early on, because while those moves do help reduce the load on the axial skeleton, you probably get a little bit more load on the SI joint or through the SI joint. And so at least in the early phases of things, we want to kind of be careful with that. But again, too, if those moves don't hurt, then they have access to do that. But it's just another little tidbit that you probably want to be cautious of. So point being, it's the same story. Get variability, get power, get capacity, get after it, and get them out of there in your life. Use your tests to guide your judgment. Don't use the SI joint tests. They're not going to add much to the mix. So, Chris, thank you for a good question, as always. And Dexy, I appreciate you having you here. You have a good New Year, too. I hope you had a good New Year. Next question. This is from Gerard. I think he's on the Instagram, baby. I don't know if he's here today, though. Gerard. Hey, Z-Money. Nice. Could you please explain when you would incorporate a slide board for reverse lunges into a strength conditioning or even PT program? Would it be after weeks of crushing normal reverse lunges under significant load? What type of client do you look to use the slide board for? I love them, but am sort of unsure when to incorporate it. I like to off-let set, use the safety bar. How do I decide when? It's all so good. Gerard, phenomenal question, my man. to be perfectly, well, no, I'm not going to say that. I typically don't use slide boards that much, personally. One, because I don't have an access to a slide board right now. I do have valve slides, and I have been playing around a little bit more with those. And in something like a reverse lunge, or really any type of lunge pattern, when I'm thinking slide board or a valve slide or something along those lines, I'm thinking an intermediary between a static versus dynamic type of lunge pattern. Let me unpack that a little bit. So if I'm moving someone from a split squat where they are in place doing the level change versus a reverse lunge where they're stepping back, on the reverse lunge piece, there is a little bit of, or a forward lunge for that matter, or any lunge, lateral lunge, whatever. There is a deceleration component to that in which you have to control your landing so you don't go too far forward, so you don't, in the case of a forward lunge, put too much stress on your knee or put most of your weight on the front of your foot or all other types of things, or just fall. And the same is true with the reverse lunge. Because you have hang time in the air, there's a little bit less control involved, or there's a little bit more motor control demands required because of the nature of the exercise. And same thing with something like a lateral lunge. There's that degree of uncertainty with the leg being in the air. When would you use the slide board? If I have someone who, say, split squats Gucci, and I try to go to reverse lunge, which typically for me would be the next progression, and they can't do that for whatever reason. Maybe they can't control the landing, maybe they're going too fast, maybe they're shifting their weight forward, something is up. Using a valve slide or a slide board in that case is money, because you still get a little bit of that deceleration component with it, but because you're still contacting the ground relatively, you can slide and grade the pace at which you do so. You remove that uncertainty. And I would say the same is true for something like a forward lunge. You could argue using a slide board for that. I'd be cool with it. Definitely a lateral lunge. Also, one thing I really like for the slide board or the valve slide is an RDL. Like when I'm moving someone from, say, a two-legged deadlift to a single-leg deadlift. What if they're having a really hard time doing that hinge while keeping the body in a straight line, and maybe it's just they're falling over? Well, you can use something like a slide board as an intermediary to just teach them to start shifting back onto one leg. So it would kind of look like, hopefully y'all can see me. Whoa, sorry, Instagram. Dang. Zach won Instagram nothing. Okay. So I want you to close your eyes and imagine that I put a slide board right behind myself. Now open them so you can see me do this. Let's say my left leg is on the slide board, and I'm going to do a RDL or a single leg RDL variation. So I got my left foot there, up on my tippy toe. Most of my weight is on my right leg. I can simply slide back like so on the slide board, get up nice and tall, to start loading the hamstring, glute, and all that jazz on a single leg. So that's a really nice thing that I like using the slide board or the valve slide for. I've also been playing a little bit with kind of shifting back and also loading the hamstring this way. That's also not a bad movement, but if we're using it from like a single leg RDL progression, slide board again is an intermediary between doing something on two legs, say like an RDL, versus going to a single leg RDL. Those are typically the times that I use it, aside from conditioning. Doing the slide board side to side or the lateral sled stuff is really, really good from a frontal plane conditioning standpoint. Another good place to use them, but obviously you need the slide board. I don't use that as much right now because, homie, don't have a slide board. So really, those are the times that I use it. And if you have someone who can do a lunge and it looks pretty good and you can load it up with some of the other ways that you mentioned, Gerard, you probably don't need to use the slide board or the valve slide unless you want to mix things up for variety. To me, it's just really a means of bridging a gap from something that is less complex to something that's more complex. So that's my spiel on slide boards and valve slides. I think they're pretty cool from a lower body standpoint. I think there's some cool things you can do from an upper body standpoint as well. Maybe some neat push-up variations. I don't use them that frequently. Oh, another thought. Another good place to use a slide board. If you're doing like the hamstring curls, like on the physio ball or a gymnic ball, which is what we have. That's our brand. No affinity to them. Going to a valve slide or a slide board with those bad boys, oh my God, cooks the hammies, hammed like bacon, if you know what I'm saying. Like, that is a really good variation, and that might be a damn near terminal progression for those moves, unless you're going to like a Nordic hamstring or something like that. That's also another great use of the slide board or the valve slide. Definitely, like, I did those the other day, and I was smoked. Those are really, really good moves. And then you can progress that, obviously, to single leg, lots of different things. There's lots of different options with that. Also doing like an ab wheel, get rid of the ab wheel and use like valve slides. Rectus damn near killed us. Six-pack abs will be on fire. Another great place to use them. So for some of the less compound movements, slide boards are probably more on the higher end of things, whereas with more of the compound movements, they're probably more intermediaries. So those would be kind of all the times that Z Money would use the slide board, as you call me. So great question, Gerard. Appreciate your contributions. I hope you find use for that and slide away. Next question comes from Tyler. Hey, homie. I have a question / idea for the next movement debrief. What are the benefits of flexion-based movements for lumbar disc herniations versus extension-based? Also do an R&B debrief, please. And guess what, Tyler? I'm going to do both. But first, let's talk about bulging discs. Let me get some water because this is going to get serious. First off, before we go into the flexion versus extension whole jazz, let's talk about when the diagnosis bulging disc is actually relevant. Because everyone and their brother and dog has a bulging disc. I can't tell you how many times I work with an individual who has low back pain who says, well, I got, 3 bulging discs and they don't have any radiating symptoms. Then that's okay. Because that's the biggest thing with this is, do you have symptoms going down your leg? And let's even take this one step further. Do you have neurological symptoms going down your leg? Because that's really when having the imaging match the clinical findings, when this stuff becomes relevant. Because what I think goes on a lot is you see clinicians who someone has back pain and they immediately go to imaging. And that is, one, not in line with the evidence, and two, based on the education that most of these patients receive, probably harmful. Because imaging unto itself doesn't mean much if you don't have a corresponding clinical presentation with it. And so to say you take some pictures of someone's back and they have bulging discs, well, if you look at the research, depending on who you read, could have anywhere from 20 to 80% of the asymptomatic population has a disc bulge. Facts of life. And I think in my pain talk, I forget the exact statistic, but I think it was like, 30% of people at the age of 20 have some type of abnormal findings in their lower back. So, point being, we have to kind of reason through the clinical process. Is this an incidental finding or is it not? And if you look at the imaging alone, you're not going to get that answer. Now, if we look at people who are symptomatic and we do imaging with them, the incidence of having some of these abnormal findings is much higher, which would make sense because sometimes, guys, nociception does equal pain, and pain and tissue damage are related. But you have to look at how the person's presenting to decide that. And so when first off is a bulging disc serious? Signs and symptoms down the leg that fits the level or fits near the level. So that's where your neurological examination comes into play. If I have sensory loss, if I have motor weakness, and if I have reflex loss that fit where the disc bulge is or around that area, that's when this is really a problem. Very rarely is that the case, though. Think about other potential neurological signs you could have. You could have like saddle anesthesia where the goods have a loss of sensation. You can have alterations in bowel and bladder function. If you're having these things, then maybe we're going to be a little bit more concerned about a disc bulge. But even if you have some of these things, now, first off, if you got the changes in bowel and bladder, saddle anesthesia, yo, I'm punting. See ya. We're going to send you to a doc because that could be very compromising if that disc bulge continues to increase or you get an even greater inflammatory process occurring at the spinal cord. So that's piece one. With the neurological exam, is there a referral? Is there not? Depending on what symptoms are prevalent and how long these things have been going on, it may or may not be. It's kind of a 50-50 shot. If you have reflex loss, and I might not be updated on the research, so this was something I read 2011, so please fact check me if I'm incorrect on this, guys. But if I have reflex loss that corresponds with the level of the disc bulge and fits the clinical picture, the outcomes are generally worse. So for someone like that, you may want to refer. And it may not even end up in a surgical thing. Maybe they do some type of injection, which for as much as I have disdain for injections, in some cases, that shit's warranted. Maybe if I have a substantial inflammatory process occurring at a certain level in the spinal cord, sometimes mitigating or reducing that anti-inflammatory process to a degree can be incredibly helpful. For Hadur, appreciate you, my guy. So if you got reflex loss, you may want to send back. Motor weakness, it's kind of one of those 50-50 things. I go back and forth on this because sometimes you can have people who have weakness secondary to pain, and other times you can have weakness secondary to motor loss from, say, a disc bulge compromising one of the nerve roots. So it's kind of hard to say. With someone who's just has like sensory and motor, it would depend on the degree that the motor loss is present. If it's minor, if maybe they can take some resistance but they fail, versus a complete drop, in the former case, I may actually take a shot at treating them. In the latter case, I may refer back just to be on the safe side. Sensory, if it's just sensory, you can likely treat these people because sensory is typically the first thing to go with some type of ischemia of the nerve. And sometimes if you do some type of activity to improve upon the mobility and the neural health or the neural container health surrounding the nerve, so the structures that encapsulate the nerve root, maybe you do things to offload, that could potentially be a little bit more something treatable. So first off and foremost, make sure you got, hang on, what's Joey saying? Yes, Joey, I agree with you, man, on that imaging. But yeah, so check your neurological examination, guys, and make sure that there's someone you can help. And if you know what the signs and symptoms are of who you can help, then you know when to refer. So that's piece one. But let's say this is someone who we can help, and let's say this is someone who has some radiating symptoms down the leg, whichever leg, it doesn't really matter. And let's say it is related to the bulging disc. What do? When would I use flexion versus extension? Conventional wisdom, and let me preface this, so I'm not super well versed in some of the McKenzie stuff, which typically when you think bulging disc or doing, I have symptoms going down the leg and I want to centralize them, because the closer to the spine symptoms get, generally things are better. That means less of the nerve tract is compromised, or not compromised, but impacted or sensitive. Always a good sign. I'm not super well versed in the McKenzie stuff, and I think that is what Tyler is asking about. But I will say this, you need to find some type of treatment that centralizes symptoms. But I don't think it has to be a directional preference kind of thing, because I think you can centralize symptoms multiple ways. Perhaps doing some type of end range extension, like a press up or something like that, which, if you look at the research, is likely not pushing the disc material back into place, because a lot of times these people who have bulging discs may be pain-free 3-4 months down the line and still have the disc bulge. Research shows it takes about 7 to 9 months for these bad boys to heal. So the discs can go back, or the material can be cleared out by the immune system or something along those lines. So maybe something like extension of a prone press-up is stimulating mechanoreception in such a manner that it leads to a symptom reduction, and maybe you get kicking in of some endogenous opioids and cannabinoids, which can reduce inflammation around the area involved, and maybe that helps reduce symptoms. That said, even if someone has a worse directional preference with flexion, you could probably still do wonders with flexion-based activities. Here's why. If we think about this from a biomechanical standpoint, if I'm getting some type of compression around the nerve root, or the disc bulge is posterior and the facets have kind of closed a little bit on the area of the nerve, so there's less mobility, especially if the nerve is inflamed, what is going to reduce some of that posterior compression? Flexion. And you don't have to get that by doing, these Williams flexion-based exercises or anything like that. But maybe it's doing the same stuff that you do for anything else. It's restoring variability, because when I have a loss of variability, or I'm in pain, or I'm stressed, and I use the term very loosely, the system is stressed, you're going to go to a strategy that reduces degrees of freedom, alters your breathing pattern, and does many of these other things. And that could potentially put an individual in a position that makes them unable to offload the neural structures that are affected by the bulging disc. And so if you restore position by maybe some type of flexion-based exercise, it doesn't have to be some crazy posterior pelvic tilt, you can do the same thing with an exhale. That may be enough to create a little bit of traction through the posterior aspect of the spine, alleviate some of the pressure off of the nerve that's effective, and lead to the same centralization. So when would you use one versus the other? Depends on your patient. Depends on your client. It depends on how you present. It depends on what movement capabilities you have versus you don't have. Because I could argue either way. I could argue doing a relatively local input by doing a prone press-up to potentially get mechanoreception involved, opioid stimulation, all these types of things. You probably get also the conditioned pain modulation, because sometimes extension hurts. But with flexion, you may get the exact same results for a completely different mechanistic reason. And I'm certain that both of the mechanistic reasons that I told you guys will probably be incredibly false a year from now, or 2 years from now, or even right now. It doesn't matter. You just have to know what you're trying to do, know what you're trying to accomplish from a movement standpoint, your intent. Make sure that your client executes with flawless performance of that activity that is supposed to ameliorate symptoms, and then recheck yourself. Make sure you got the outcome you wanted. So you can do either. As long as you're helping people, as long as you're getting the changes that are meaningful to yourself and the patient, then you're going to be okay. And I don't hold affinity to any one exercise or any one system, because People get results with McKenzie. People get results with flexion. People get results. People don't get results too, though. So just make sure you have some type of clinical process that you're going through when you're making these decisions. Now, that said, one cautionary measure on neurodynamic stuff. And I got to give kudos to my boy, Michael Shacklock, because so I met Michael in the land of China when I was speaking there. And, well, first off, bro was starstruck because Shacklock was one of the first guys who I came across when I was really starting to dive into physical therapy and rehab. And he, for those of you who don't know who Michael Shacklock is, seriously, he is like the neurodynamics guy. And I know a lot of like David Butler and some of the people I talk about are very much into neurodynamics. But I would say that based on Michael's book, and his book's a little bit older, so I don't want to speak on his behalf, but based on that book, because he may have changed some things up now, but he would be very much more of a biomechanical based guy for the nervous system. And I can appreciate that for him because he's really big into nociception, and I love that about him because I think a lot of people who really go down the pain science rabbit hole forget about that. Yeah, that actually does kind of happen. People do get hurt. People do experience pain. But when we were talking at lunch, he was telling me about this study that he did where they measured neural mobility in people who had, I believe it was disc bulges. And if you perform nerve mobilizations on these people when the disc bulge is prevalent or there's an inflammatory process going on, you actually can get a worsening of the nerve mobility and an increase in symptoms, which I thought was pretty remarkable. Because a lot of times you're going to see neurodynamic changes on these people. And I think the rationale was there's problems with the neural container, which is the stuff surrounding the nerve tract. So the disc, the facets, all the muscles surrounding that. And if you try to mobilize that without addressing the container first, you got problems, fam. So that is one thing with, especially an acute disc bulge, you absolutely want to be cautious with. Make sure that you're probably, and this is, I would say this for, I can't think of a case right off the top of my head, although I'm willing to be wrong, where I wouldn't go about it this way, but I would always address the container before I address the mobility of the nerve, or at least what we think is going on. Because if you have a limitation anywhere along the nerve pathway, then the full excursion of the nervous system is going to be limited. If I have a limitation in hip flexion, as an example, that's going to impact the excursion that the tibial or the sciatic nerve would be able to go through. So until you address the container problem, you're only going to be able to mobilize the nerve to a particular degree. So check your container first. Pick whatever move is going to be helpful for that individual. Once you've restored container health and you get a centralization of symptoms, then maybe you can consider creating a little bit of mobility through or along the nerve tract that is involved. And that would be what I would have to say about bulging discs. So Tyler, thank you for question 1. Now let's get serious, guys. Question 2, R&B debrief. So for those of you guys who don't know, I kind of like hip hop a lot. Like a lot. Like probably too much. Like that's all I'd be listening to. Like that new Sahai the Prince joint. Ooh, fire. But my second love might be R&B. And for those who don't listen to R&B, you guys should. And so here's how we're going to debrief this. Here's who you need to listen to right now. My number one guy, and I'm going to go like very, very close to R&B, but my number one guy right now who's new, write this down, BJ the Chicago Kid. He is so good. Listen to his song Church. You'll thank me later. That one's really good. I really like his stuff. Who else do I like? I don't know if you count Black Bear as R&B. I mean, Black Bear is the man. You gotta listen to Black Bear. I also like Anderson.pack. And I'm gonna link these guys in the show notes because that's what I do. But Anderson.pack, give him a listen. Those guys are like my top 3, like more modern R&B kind of peeps right now who I like to listen to. So, Tyler, that's who you want to go after. I'm writing this down because I'm going to link all these people. These are the important links, guys. Who else? BJ. Oh, Dwelle out of Detroit. He's got some good songs. There was a joint that he did on the Prime album, which is, for those who don't know, DJ Premier, Royce da 5'9". One of my favorite producers and also one of my favorite MCs. But he did this chorus on the song called You Should Know. Really, really good. I got into some Dwelle. He's good. You want to give him a listen as well. In terms of older people, now like 90s, 2000s, that stuff would be my jam. I really like R&B from that era. So got to give props to Casey and JoJo. I got to hear them live for the first time last year. Unbelievable. Genuine, also good. Not that great live, but he still sings. He's got some stuff. So I like me some Genuine. Case and Joe, both those guys, absolute fire. And of course, how can I forget R. Kelly? Kills. Yeah, he did some questionable things, but what wasn't questionable was his music. So you definitely want to give those people a listen to if you haven't already. And I'm trying to think if there's anyone else. Like, those are the people off the top of my head who really tripped my trigger from an R&B standpoint. Yeah, we're going to go with that for right now. Maybe I'll do a blog on R&B one day. Probably not. You guys wouldn't read that. But anyways, that's my little R&B spiel. Listen to those people if you want to get into R&B. And if you want to get even more into R&B, just go ahead and message me because I'm sure there's a lot of other people who I listen to. Oh my gosh. Forgot one. Music Soul Child. Oh my God. How can I forget music? So this guy, like, I saw him live as well in Phoenix. His voice is unreal. Like, absolutely unreal. Listen to music. And my favorite song by him is Teach Me. That one's really good. It's like he's like this guy who's just been working really, really hard, trying to provide for his missus, and he hasn't been loving her as much, and then so now he's like, teach me how to love and stuff like that. So it's good. Give him a shot. That's really all I can think of right now from an R&B standpoint. So Tyler, another good question. We'll have to talk a little bit more about R&B. But anyone else has any other questions? Fire away. Otherwise, I think that's a good stopping point for tonight. I want to thank everyone for listening in tonight. I appreciate all you guys being here. I hope the New Year's was great. You're probably wondering, where can I find out more? Well, I'm glad you asked. First, ZachCouples.com. Sign up for my newsletter. You'll get almost 3 hours worth of me talking about pain or breathing and almost 50 pages worth me, typing all that stuff out. So you definitely want to check that out. You'll also get a free acute to chronic workload calculator. You'll get access to some other talks and content. Guess what, guys? Newsletter subscribers get a discount to my product when it comes out. It's going to be pretty mega. So you probably want to sign up if you haven't already. While you're there, maybe you need some other services that I offer. I offer mentoring. Are you having patients that you're struggling with? Are you having clients that are having a hard time getting buy-in with certain things? Are you having trouble making good clinical decisions on the fly? Do you want to understand some of the stuff that I've talked about in these debriefs and on my blog a little bit better? Do you want to be better at what you do? I can be your guy. Come hit me up on the mentorship program. I'd be happy to work with you. I got quite a few mentees right now, and we got some really good sessions going on, and it's mutually beneficial. And I really enjoy working with these people, and I try to put as much effort as I can into making that program great. So please go ahead and check that out. Maybe you're a little uncomfortable, you're a little toit, and you tried some other stuff, and you ruled out the big bad stuff. You ruled out the bulging disc. That was a problem. And you're wondering, hey, maybe this joker Zach can help me. You know what? I damn well may be able to. You should go ahead and check out my movement consultations. We can get you moving in 3 planes, moving and grooving. We can coach some maybe of the lifts that you're having a problem with. I don't care, man. Whatever you want help with, I can do it. Go ahead and check me out. Do you want gains? Do you want losses? or you post rehab, you need training. This guy right here, he can help you out. Go ahead and check me out for online training. I can hook you up with that as well. On the social media side of things, Facebook.com/ZCouples. Also got Zach Couples PT, which is my professional page. Fam, I'm going to be switching to that soon. You may want to like it. Also got Twitter, the handle, ZCouples. Check me out. Sometimes I post profound things. Sometimes I don't. I'm trying. Check me out on that. Instagram, baby. Instagram.com. Zach, Z-A-C, Couples, C-U-P-P-L-E-S. Hit me up on that. Hiking pictures, quote boards, oh my, all types of stuff. Check me out there. Also on YouTube. Just search Zach Couples in YouTube. You'll find me. And then just hit subscribe. Because a lot of times, guys, on the YouTubes, I put exercises in there that I send to my movement consultation peeps. Put exercises on there that don't make it to the blog or make it anywhere else. You may want to check me out on that. Otherwise, thank you guys so much for tuning in. You're all wonderful. Hope the new year is outstanding. Hope 2018 brings you wonderful things. I look forward to going through it with y'all. Appreciate you being here. Stay hungry, stay learning, stay moving. I'll see you next time. Deuces.